Okay, so yeah, this is a presentation on transference, and it will be a two-part presentation, first theoretical and then following a clinical vignette. So I'm going to start a bit with history and some overview of what transference is like. So Freud, very early on in his study of the hysterics, and seeing Breuer work with Anna O, realized that when you let people talk, when you let the hysterics talk, you come up with various kinds of resistances and emotional changes in the process. And was the this was what to become as transference. So Freud's first conceptualization of transference was actually as a resistance in therapeutic work. So he thought that transference was an obstacle that you have to overcome to achieve the goal, and goal, so to say, to be cured in analysis. Right? But in the hysterics, it was not really as clearly present, the transference. So it's actually in the Dora case where you see really transference taking place, and how Freud had to grapple with the problems um, of transference. And that, as we know from the Dora case, it's just very difficult. But nonetheless, transference isn't always negative. Transference can have positive aspects to it, and that's what we're going to see. And then one of the ways people talk about transference is not necessarily always clinical. So when you hear psychoanalysts speak about transference, it's almost always transference during treatment. But as you see in Greenacre's paper on transference, she argues that transference is actually a very universal and general phenomena that happens when you have interaction between two people. This is not something that everyone agrees upon, but Greenacre promotes this, and a lot of other schools do too. So, as I said, Freud's first conceptualization of transference was that of resistance, and the patient was having problems from recalling these repressed memories. So, again, when you talk in analysis, you're trying to recall the repressed memories, and transference, as Freud understood first, was actually an obstacle to the recollection. So this is what happens in the Dora case explicitly, and if you look at the postscript present in the case, there Freud adds, after the Dora case is over, how the importance of transference and how it is related to the Dora case, and also he also gives the theoretical formulations which would later be necessary. So that was Freud's early view, but Freud changed his views soon enough, and now he understands transference as a positive factor, and this factor helps in the progress of the treatment. So as he continues and develops on this view, then transference becomes one of the core pillars, along with the talking cure, of course. This becomes one of the core pillars of psychoanalysis. So it becomes so much connected to psychoanalysis that psychoanalysis without the involvement and analysis of transference cannot be called psychoanalysis anymore. So that's what Freud moved on to. Now, if we try to ask ourselves, what is transference exactly? Is it a resistance to treatment, or the opposite, that is a progressive factor? And if so, why is it like that? Why is it in transference that you have resistance coming up? Or how is it exactly that it helps in progress? So this, when you ask these questions, you lead up to an inherent contradictory and paradoxical nature of transference. And this is present in one of the papers from the papers on technique collection of Freud. And this quote, exemplifies that when he says, thus, transference in the analytic treatment invariably appears to us in the first instance as the strongest weapon of the resistance. And we may conclude that the intensity and persistence of the transference are an affect and an expression of the resistance. So this is Freud telling us that in the first instance, it is the strongest weapon, and it's like resistance at its most strong manner. That's what Freud says here as transference. But then you hear the exactly opposite thing, as Laplanche and Pontelli in the dictionary tell us, that inasmuch as it offers the superlative way for the subject as for the analyst to grasp the elements of the infantile conflict, the transference becomes the terrain upon which patient's unique set of problems is played out with an ineluctable immediacy, the area where the subject finds himself face to face with the existence, permanence, the force of his unconscious wishes and fantasies. So this is here, transference is no longer resistance or like the strongest form of resistance. Now, transference is basically the ground, so to speak, on which patients' problems immediately play themselves out. Right? The unconscious wishes, fantasies, so to speak. And Freud, in one of his two encyclopedia articles, also kind of puts a final word on this when he says, this transference, alike in its positive and negative form, is used as a weapon by the resistance, so that's what we said, but in the hands of the physician, it becomes the most powerful therapeutic instrument, and it plays a part scarcely to be overestimated in the dynamics of the process of cure. So you can see, the paradox and the contradictory nature that we mentioned of transference. It is exactly what Freud is saying here, that it has the positive and the negative form. So it is the strongest weapon by the resistance. So like resistance in its most strongest form, but in the hands of the physician, transference becomes the most powerful therapeutic instrument. So it's one of the tools in the tool set that you can use for process of cure and analysis. So transference is related to a lot of other concepts in psychoanalysis, but one of the things that it is related to is repetition, because one of the special things about transference, which makes it such a fruitful thing for analysis, is the subject's repetition and reliving of past experiences. So this is basically subject, the repressed memories, as we said before, those things manifesting themselves in the form of transference is basically the subject's repetition of those experiences and the reliving of those experiences. So here, transference, again, this is basically what is the tool for the physician, for the analyst, right? So as the analyst cannot directly, so to speak, infer the memories or the experiences of the patient, transference is where the analyst gets to see the patient relive and repeat the past experiences. So, so to speak, we can say in transference, the unconscious fantasies and memories emerge from the history of the analyson and restructure themselves in the analytic relationship with the analyson. Right? So what happens is that you have unconscious fantasies, unconscious wishes, memories, whatever, and they emerge from the history, from your history, right? And not only they just emerge, as in the sense I remembered a memory or that now I have a reaction, so to speak, but in transference, they restructure themselves in the analytic relationship. So now the memories, the fantasies, they now have taken a different form, so to speak, in the relationship you have with the analysis, with the analyst, right? So that's another thing. And And this is what also Freud says, that when we're remembering something in transference, it is not a complete recollection of the repressed memory. So he says the patient cannot remember the whole of what is repressed in him. What he cannot remember may be precisely the essential part of it. He's obliged to repeat the repressed material as a contemporary experience. So what happens is that you cannot remember all of what is repressed, right? If that was the case, then uncovering the unconscious or the analytic process would be easy. But as you cannot remember all of the repressed material, what happens is that you're obliged to repeat the repressed material, as Freud says, as a new experience, as a contemporary experience, right? So this is kind of at heart of how we understand transference, as the kind of loosely understand transference is the transfer of affects or transfer of feelings, transfer of something from one place to another, right? So here we can see that as you cannot remember all of your memories, all of it is repressed. So what happens is that things get transferred from what is repressed into the new arena. And in the new arena, they repeat themselves as a contemporary, as a new experience. And this is what you see in analysis with the patient. So this is just as a side remark that transference often can be seen as, so to speak, the transfer of feelings from one place, one thing, one object onto another. And often in clinic, it is basically early kind of object, choices or object relations, and they get targeted to the analyst. So moving on, what we come to is how transference works with object relations. Right? The object relations school, how it understands transference. So transference is quite a fundamental concept in object relations. And we had a previous presentation where we saw one form of therapy which centers transference around it, and that kind of therapy also originated from object relations, and I'm going to talk a bit about that. So from the object relations orientation, transference is the phenomena where intersubjective relationships, whether it is mother-infant relationship or other object relations to certain people, certain things, certain experiences, these things find a way where communication is now possible. So like you had early object relations, intersubjective relationships, and transference is when those object relations now find a way of communicating. It is like they're now finally being expressed, right? And yeah, so that's what you understand as transference in object relations. Now, clinically, in object relations, it might look something as what we said. Right? So, Kernberg and others have formulated this form of therapy, as Sean in his last presentation said, the transference focus therapy. And what they say is basically, again, what I said. It is the expression of things which are now possible, and they were not possible before, object relations. So yeah, if you look at the book by Kernberg and his colleagues on transference focus therapy, he says exactly this. He says, in contrast to the approaches described so far, TFP allows the full activation of the patient's distorted internal representations of the self and other in the present relationship between patient and therapist, right? So it is to be expected that primitive object relations will be activated in the treatment setting because as the patient's dominant motivational systems, they are constantly active in the patient's life. Patients use the treatment opportunity to let these object relations unfold, and the therapist tries to analyze, clarify cognitively the patient perceives at the most profound level. So basically, what happens, as we said, is that in the therapeutic relationship, TFP promises you to have full activation of all the distorted internal representations of yourself and of others. And those things get activated in the relationship between the patient and the therapist, right? And what TFP expects is that when these primitive object relations are activated, um, you know, they're activated in relation to the dominant emotional things that the person is going through. So it's kind of like the patient is going through right now a lot of trouble, and those troubles activate some primitive object relations from early on, and then those activations kind of come to the present relationship between the analyst and the therapist, and analyst and the therapist. So, after this activation, after what happens, patients use the treatment. The therapeutic relationship, the patients use that to have these object relations play out, and then the therapist kind of acts as the person to analyze and kind of clarify these primitive object relations which are now appearing, and kind of, so to speak, reinterpret them with the patient. And this is again a side remark of what I said in my last presentation, or the last presentation on the analytic process, when I talked about the beyond's conception of container containment, how the therapist is basically kind of it acts as, again, the alpha function. Remember, the alpha function is basically what turns beta elements into dream thoughts. What you can dream, and so to speak, the therapist allows as a container for all the primitive object relations that were like, what do you say, so to speak, uninterpreted, or in some ways distorted, and the analyst can act as a container for those things. That's a kind of Bayesian interpretation of what is being said here. So again, the last point is these scenarios are not simply a literal reproduction of what happened in the past, but are a combination of what happened, the patient imagined happened, and what the patient defensively set up to avoid. So this is one of the interesting things, is that in transference, it is not you kind of literally remembering what happened. This is what we said, Freud said you cannot remember the entirety of the repressed memories. So this is not a literal reproduction of what happened, but like it's a combination of what happened. So there's a bit of what happened, then there's a bit of what the patient imagined happened. So what the patient thought of the situation, of the condition, what the patient imagined it to be, and then lastly, what the patient defensively set up to avoid. Okay? So what the patient kind of formed as a defense on how to avoid from what happened. So all these three things, they show up in transference, right? And this is why really transference, so to speak, is the treasury of a psychoanalytic relationship, because without transference, you really do not have much to work on. At least in the case of the neurotic patients and psychotic patients, I believe things would be different. But in the treatment of neurosis, it is basically transference which gives you the material to work on. And you can see from all these three things how much and how divergent things you can get from transference. And this is exactly why transference matters. right? Because um, it allows you to know more and to kind of allow the patient to learn more about their relationships of to their symptoms, to their parental relations and all of those things in relation to the analyst. So it is not again just a remembrance. It is a remembrance in relation to the analyst, and this leads to all kinds of difficulties in analysis. Even sometimes when you are treating as difficult patients like borderline personality, you would have very harmful behavior manifesting itself in transference. But at the same time, as we know, right? So this is basically what you
Did
have.
you? Oh,
Sorry.
you cut, I think, or you paused? I don't know.
Oh, did you didn't hear me for a second?
No, for a second it cut. Yeah,
Okay, okay, okay. Yeah, I think yeah. Last thing I was saying was borderline personality.
yeah.
Basically, that's my last point before I give you the
All right.
yeah. The last point is basically, in borderline personality, you have a lot of harmful things showing up in transference, and you can think that okay, these are so many harmful things. Like, why should we do care about transferences? Because as we see from Kernberg's work and other people's work, that when you have a treatment such as transference focused therapy, um, you realize that it is in transference that the borderline realizes its actual kind of, what do you say, relationship to its symptoms. So before transference, it is kind of caught up in this distorted representations. Like it doesn't know what actually happened, what he thinks what happened, and what is kind of a defense. So it's always kind of mixed up. And in transference, if you allow these things to show up, the patient realizes what's there and what's there not. So that's kind of the point on why um, transference matters, because it tells you and it tells the patient more about certain relationships. So that's the last thing. And just before I give you the case, the vignette present, I'll just would like to tell that, of course, we didn't touch all kinds of transferences that can happen in neurosis, psychosis, perversion, or other structures, because that's a very difficult and extensive thing to tell about. We'll probably cover it in future talks. But I would like to give two references on where to look for perversion. So if you look at Freud's work, you'll have to look at Freud's work on sexuality. So starting from the three essays, you go to child is being beaten and fetishism. Fetishism is probably the kind of last around the late works of Freud on this. So that's where you can learn Freudian directly from Freud about perversion. And then if you're going for much more Lacanian orientation, like Lacan of course talks about perversion and a lot of the related things almost everywhere. But like, if you do not want to get lost in Lacan, secondary references are chapter 9 of Bruce Fink's Clinical Introduction, and Joel Durr's Structure and Perversions. Those two are really good ways of good places to look into perversion. So with that, I will give over to Jade for the clinical vignette.
Yeah, I will try to make bridges between the theory you have explained, and maybe this case, which is extracted from a good read that you can find, I think, for free on multiple websites. It's about 33 pages in English, published in the British Journal of Psychoanalysis or Psychotherapy. And I think it's a good read because it explains the view of Estella Weldon on perversion. She actually makes a good argument for the feminine perversion, which she explains at the end of the paper. But she also explained this case that she had at the beginning of her therapeutic career, and is actually quite a difficult patient, as she is saying. So she wrote, shortly after my arrival at the Portman is a clinic, and anxious to have as many difficult patients as possible, I was allocated a young, attractive, recently married man with an apparently unusual sexual perversion. So this clinical case is treated with 3 times per week, psychoanalytic, well, face to face, well, on the couch, and not face to face, which is quite rare actually. But so this man is seen 3 times a week for multiple weeks at a time. And so she explained what this perversion, unusual sexual perversion, is. This, he told me, involved the use of a complicated rubber gear all over his body, including his head and limbs, with the aim of producing an almost total sensory deprivation. At this point, uncertain of his own survival, he would reach orgasm. If anything went wrong, he would face death. So already you can see how this is an unusual sexual practice, and you see already that, well, even the rubber, the material that is used, Estella says that it was as thin as a second skin to be used over the body. You will see that this is an important detail, which would lead Estella to make important interpretation during the process, the analytic process. She says that, well, now she links that with Mr. Big's concept of the skin containing the self and of narcissistic or adhesive identification, which already is showing the analytic part. Now, with this classical cure, we can see who is this patient. So we know that he's a young man. He's actually successful, good health, and yet there is this sexual, almost unusual practice, as she said. And she's gonna, I cut parts of the case to make it just about the case, but she explains a lot during this this paper of where she progress in analysis. So you will see that I restructured the paper to fit our transference discussion here. But at first, you can see that, so my patient, despite his apparent success and well-being, was in need of a second skin to be used, not only as protection against all possibilities of pain, but also as a container for anguish and anxiety of paramount proportions. After the wedding, they moved to a new home, so he is newly wed, and they moved to a new home, but at that point, all of his previous mail was forwarded to the new address. And in this mail, we can find many magazines and publications on autoerotic asphyxia. So autoerotic asphyxia is this unusual practice where you cut all stimuli from the external world, just to feel this kind of pressure on you that you will almost die, then the people reach orgasms. So it refers to this second skin practice that the patient have. And so the wife discovered this practice because the patient never told his wife about this. He never actually, you will see that this denial, this kind of dissimulation is part of the perverted structure also for Estella Weldon. You can see that at first she tries to inform herself about this practice. And then we can ask ourselves, is it curiosity or transference? But you see that she already is stating facts. So, for example, she explained the title of her paper. It is not such a rare phenomenon as I had previously assumed. Dancing with Death is therefore not just a dream glam title. Most of what is factually known about autoerotic asphyxia comes from research on post-mortem finding done mostly in Canada. So you see that what we know from this is from death already. So it's not far-fetched to link this sexual practice and the fight between life and death, this thin thread between the two. Revealingly enough, the corpse usually have evidence of association with other perversions, such as wearing babies' clothing, and so on, which shows different particularities of perversion, but it doesn't interest us for this case. Under his wife's threat, so she discovered this unusual practice, and she threatens to divorce unless he undertake psychotherapy, which he does, with actually a great deal of curiosity. And you see that he is trying to be an ideal patient, but to no avail. So he's coming on time, he's doing his work, yet there is not much progress. And actually, Estella does something here that not many analysts do, is to explain that this may be her fault because she could have been too anxious to be the perfect therapist. Remember, this is in her early career, and she's trying to be too clever. She goes on and on with that, trying to explain that she understood too quickly, that she tried to make interpretation too quickly, and typical mistakes of analysts, of beginner analysts. And so we can ask ourselves, okay, but going to a sex shop, which is what Estella did, she visited a sex shop to understand this unusual practice. And she told her colleagues that, well, she visited the sex shop just to understand what all the fuss about. And the colleagues judged it as a counter-transference reaction, which is a reaction from transference by the patient. So she is being seduced by the patient. You can see here that perversion has this side with analysts, where analysts are extremely careful. They already have a lot of ideas on how to deal with perversion and the danger related to them, and so they are being judgmental and telling her that this is a counter-transference reaction, which is more of a curiosity thing than really counter-transference. And she explained herself. She actually says that there is a tragic struggle in which these people find themselves, literally between life and death. It's not only some sexual pleasure where the perverted always wins. No, he's actually suffering from this, and you will see later how this makes sense. The patient tell Estella that he feels like he is between life and death, that he has this normal life. So remember, he's a successful man. He's a pretty man in good health. So we are far away from the typical patient that we see in the hospital. Which are in bad condition. No, this man has everything someone would wish for, but yet there is this perversion, and if he cannot perform it at least once a week, then he doesn't think he could live. Actually, he wants to appear as normal. He wants to be this normal human being, but yet there is this thing that he must practice almost like a ritual every week. He knows about this from early adolescence. He fell in love and assumed, hoped, wished that he was over his own peculiarity, so he never bothered to tell his future wife about it. You can see denial, self-rejection are very present here, which are common mechanism of defense. And you see here that Estella tells us that deception, although frequently ignored, is yet another constant characteristic of perversion. Others call it false self, pseudo-normality, the as if. It's all related to the same concept, which is deception, right? And deception here is illustrated with the fact that he lies about to his wife. He never told him this. Now, to get to the point where Divya said that Freud and every analyst really consider transference as the key part of the analytic process. And you will see why. Now I'm trying to illustrate why it's so important, why it's the key that will help us and the patient be beyond a mere conversation, because from now you could almost feel like Estella is some kind of priest, some kind of priest where the patient comes and make confessions, which is what Divya said. There is transference in that too, but the analytic transference is different in the way the analyst uses it. Here, she says, something began to emerge. Because at first, there was nothing in the relationship. He wanted to be the ideal patient, but yet nothing emerged. Now, something began to emerge. It was positioned in the worlds of affects and feelings, and was communicated between the two of us without words. It was as if we almost became one. A sort of a fusion or overlapping was taking place between the two of us, reflected concretely in the mood of the session. This can sound mystical almost. There is a nice footnote where she explains herself, and she actually analyzes reference, but it's long and I couldn't go over it here, but I suggest you go read that because it will actually make sense. Because here, the fact that she says that we became one can be understood in many ways, but don't worry, it's still psychoanalysis. Now, this is transference. She's trying to put words on the process of transference. And she actually knows where it comes from. The small consulting room had become almost like a containing uterus. At the end of the session, I could be left with the feeling that his life was actually endangered. So, you see that transference is not only caused by the analyst or the relationship, but also within the room itself, within other variables of psychoanalysis that make transference possible. The fact that the patient comes in time and so on. She said this, and this is a mistake from her part. You will see now counter-transference, but what we can call it negative in a way where it's not hate or something like this, but a mistake. I made my traditional weekend separation anxiety interpretation. So what does that means that she's leaving the patient for the weekend. Along the lines that he would resent being without me, as he would like me to take care of him over the weekend. Without hesitation, he responded, "Of course, I would love that. Shall I ring up the wife and tell her about it?" She says, this left me speechless. The concrete answer was such that I quickly learned how to shut up and how to make a better use of my countertransference. So you see that she is worried about him, but him, not that much. Or at least, that's what he says. A few sessions goes by, and then he comes with this strange experience. Something that happened during the weekend, and he comes Monday, I think, and he tells her about it. The previous night, he had been watching television with his wife in the lounge, and suddenly, and unexpectedly, had felt taken over by an overwhelming desire to make love to his wife, right there and then, on the floor. He is quite surprised of this. He said it was most peculiar, because the screen was showing nothing remotely romantic or even erotic. What was the screen showing? It was actually a documentary on Houdini. The guy who escapes everything. Great magician. Going up and down the rapids, so he was trying to escape from a box. This image had produced in my patient an influx of sexuality which he couldn't control at all. It seems to me that the TV screen did represent something very important, actually basic or crucial to your own survival, which may even go as far back as your own birth. Here, you can go back to what Divya said about repetition. This is related to repetition. And you know that analysts know that we work all the time with repetition. And this is what she is actually doing. She is saying, well, this TV screen is related to something you repeat from a long time ago. She asks about the birth. Because, well, she makes that interpretation. And so she asks him, well, what's your birth like? What was your birth like? He knows, I know that it was very difficult. How difficult? I'm not sure, but I will check with my mother. They check, he asks her, and actually, the story is quite telling. He was born 3 months prematurely, a baby of 1.5 kilos. Much uncertainty about his survival, he was between life and death and immediately placed in an incubator. He remained there for 6 months, and he began to lose weight despite his being artificially fed. So already you see the theme of the box, right? This incubator. And then after he grows up and actually go out of the incubator quite late, 6 months. He thought he would to be safe enough to be out of the incubator and to be fed by his mother. He was emotionally extremely fragile. You can understand that the relationship with the mother here is quite difficult with the child because she does not have as much contact. He had recourse only to bizarre scenarios which were not of his own conscious design. The essential aspects of this bizarre scenario included uncertainty and unsafety of the womb. So here, Estella makes an interpretation about the baby. So the baby is not safe from the womb, right? That's why they put him in an incubator. Now, this means that the womb for the patient is uncertain, unsafe. But the incubator is really safe. Only a rigid box, the incubator, could offer a sense of survival. The incubator may have been partly responsible for an illusion of omnipotence, but the price paid for his survival was represented by unconscious suicidal and homicidal fantasies, where he was either evicted, destroyed, or emerged still alive but trapped in a paranoid schizoid position from which he developed a false sense of autonomy. This is a part where you can go back to Klein and you can go back to object relation and transference. I'm not going to explain everything on here, it would take a long time, but what she's saying is that this correlation she's making has grounding in psychoanalytic theory. She is justifying herself. As in most perversion, his fragile ego had to persuade his superego to succumb to this strange activity, which was experienced as the only strategy for his survival. Again, the same thing. She is justifying her interpretation with that, which was made a long time after the patient was gone. I think it's 15 years, so don't think she's making all of this on the spot in her head while talking to the patient. No. She's actually constructing this a long time after. What she is working with is transference. Is this feeling, if you go back up, this something began to emerge between the two of us without words. That is what is putting her on the path of interpretation. It's not magical. It's just something that happens in this analytic process. We can see that this transference is not merely a tool to draw correlations or construct nice theories. No. It has effects. The Houdini box actually represents him with his need to catch hold of life, his virtual resurrection, even before his own life started as such. Now, you see the repetition here. He cuts all sensory. He's in a sensory deprivation, and then he get the orgasm, and then he get out of the suit, living again, right? So you can see this theme repeating itself in Transference. So he made this revelation, and then the work began. With Transference emerged a real work. Now, this time, he doesn't need to be an ideal patient. He is actively participating to the therapy. And she says, greatly relieved, able to participate in his therapy with a more lively attitude. We were able to reconstruct some of his early experience, which in previous session had left us both rather confused. Now something stuck was unstuck. because of transference. She goes on and on with the consequence, but this consequence is not the result of a research, so to say. It's because Estella did go to her own analyst where she worked her dream, a specific dream. And she says, if you are wondering how I made the link between Houdini and his own birth, I must confess as an important footnote that I owe this insight to my early psychoanalysis. I was subjected to a repetitive, highly anxiety-producing dream. So she talks about that dream. She explains, in the dream, I'm lying in a suspended hammock with a great sense of space and depth underneath, and I am able to move in a soft and pleasant way. But then the dream changed. The movements of the hammock become faster and faster, and I no longer feel in control. I look underneath, and to my consternation and great alarm, the space is becoming narrower and narrower, so much so that I am really scared, since I know and now notice sharp cutting surfaces just below me. The hammock shrinks, disappears, and I am left falling into a precipice. She wakes up in a panic, in a cold sweat, relieved to be alive. And so this nightmare, this dream, she goes to the analyst, work on it, and the analyst makes this interpretation that, well, there is something to do with birth, with her own birth. She goes, she asks the friend, because her mother died, how was I born? And she said, how could I ever forget it? You came up like a champagne cork, so fast, so boisterous, and I've never seen anything like it. So she was ejected really quickly. And you see the relation with the hammock disappearing and her falling really quickly. She said, I had known about it all along without really knowing. She's referring to the unconscious, of course, and the repressed, and all of those mechanisms that act in the analytic process with transference. And this is actually countertransference. Later during treatment, I could not escape my unconscious partnership with my patient. My countertransference response to him was shown in my dream, which made me connect with my own memories, allowing further understanding of his psychopathology. And, well, to end the case, the patient actually stopped going therapy after his wife was pregnant, because he wanted to commit to this father role. But yet a work took place. We can maybe hope, I would say, that he tried to construct something with that by himself. But Estella is forced to respect the patient's choice, of course, but the patient decided that this was enough. Now, this is an argument for the analysts that think that perversion always quit analysis. Indeed, he quit, but is it the same as quitting without doing any work? I'm not sure. Because actually he had good reason to do so, and she interprets this. He may have needed to escape in order to preserve me as a good object, to avoid the risk of my becoming a fetish second skin. So what she's saying is that the office where the couch and so on can act as second skin, and maybe he didn't want that to repeat itself. He may have felt the need to protect me from his desire to enclose and suffocate me. All of those are actually interpretations without much grounding, but the theory. But you can see how transference is the key part of analysis. Without it, you are stuck on a conversation that leads nowhere. With transference and counter-transference, it depends the school. Again, if she was Lacanian, she wouldn't have said so. We can enter different debates with that, but it doesn't matter. We can see the consequences and the usefulness of transference in psychoanalysis. Thank you very much.
Yeah, that was great. Yeah, I realized someone else
Yeah.
also joined actually.
Oh, really?
Yes,
Oh.
Piles. Sean joined for some time, like in the break of his work. But yeah, I'm not sure how much Puddles were able to follow our presentation. But I really want to say that this case really is a kind of, what do you say? It has a lot of things in it, and transference.
Yeah,
It's
exactly.
like, like what we picked up as transference is only like a really one part of it, because you can see
Exactly.
half of what we said was related to countertransference, which is a whole different deal. And like,
Yeah.
but at the same time, how we talked about it and how you presented kind of gives this relationship between transference and countertransference, and kind of this dialectic that we have. Um, so
Yes,
yeah,
exactly.
so I think, like, this case really complements what I said about,
Hmm.
transference and its importance, repetition, and kind of again what I also said about object relations, right? I think this was very important when you presented in the case the relationship to the birth, right? She's kind of trying to
Yeah, yeah, yeah.
know what was her birth like, and how that is related to his kind of perversion symptoms. Um,
Hmm.
but at the same time, I think I have a question. I think this is a question for both of us. Um, to kind of
Yeah, okay.
choose a case for presenting on transference, which is
Hmm.
better, hysteria or perversion? Um, because
Huh.
if you think about it, hysteria has as a structure, most of it happens in transference, right? Unlike, what is it, psychosis, where you kind of have to do other things, get the material. Hysteria
Yeah.
already has most of it. um so I don't know, but like, perversion, of course, is such a good thing, as a to look at transference. But at the same
Hmm.
time, I believe, like, perversions is quite rare in kind of staying in the clinic. It's like, as you said, they kind of go away
Yeah.
earlier, or they don't come to clinic in the first place. um
Yeah.
yeah, what do you think?
I mean, yes, of course. You know why I at first I must say, as a clinician, this is hard to find.
Mm-hmm.
I think her case, to be honest, I wouldn't have put even the diagnosis of perversion for this case. I don't think she is dealing with perversion. I think she thinks she is, but at the same time,
Mm-hmm.
no pervert would have this kind of such a deep understanding of what happens in the clinic. I mean, there is no resistance there.
Mm-hmm. Mm-hmm.
It's as if everything's, glides almost. Um, I think she wants to present something that looks like perversion because of this. How do you call this? you know, this weird sexual thing.
Unusual, right?
Like,
Unusual sexual.
yeah,
Yeah,
unusual.
yeah, yeah.
Yeah. And
Mm,
yet, I'm not sure this defines a perversion.
right. Because, like, if you look at
So,
it
yeah.
from a Lacanian point of view, like, what is the mode of negation? Is going to be
Mhm.
disavowal. But, like, do we
Yeah.
really have disavowal here? It's kind of like,
No.
wow. That's the
I
thing.
mean, there is this denial.
Uh-huh.
Um, there is this deception, as she calls it, which I
Right.
do not agree with. I mean, you can find deception in every neurosis
Yeah.
possible. Everyone lies, to be honest. So, and you lie first to yourself. So I
Yes.
wouldn't like. I think this is no. This is Estella trying to, because this is a school case. I mean,
Mhm.
herself, she has some kind of dream, right? Which relates kind of to the birth, and then this relates to her case. But I mean, how much correlation can you really do without the patient talking about himself? That's what's bothered me the most. Is that
Mm.
she, and as she says, very rightfully, and she's not Kleinian. She says this in the paper that she's not Kleinian. I don't know what she is then, because she's schizoparanoid position, but whatever.
Mhm.
Um, I think she is trying to understand her previous self, her previous career in therapy with her new eye, I would say.
Mhm.
But she
Mhm.
doesn't realize that actually she didn't respect the fact that the patient, we care most about the relationship um, with language,
Right.
and here the patient almost says nothing.
Yeah. It's kind of like
Yeah.
she's putting words into the mouth of the patient, almost.
Yes,
And
exactly.
this is, I mean, this is what you see, like, like, this is probably the difference between a genius of Freud and, someone like, someone like her, because Freud goes back to the Dora case or the hysteria cases after what, 20, 25 years, and
Mhm.
he still doesn't make any remarks in the footnotes about his own kind of
Mhm.
realization, revelation, and kind of putting words into the mouth of the patient. He's always trying to, of course, recognize his mistakes, and second, realize how what the patient said could be understood differently, right? um
Yes.
but that's kind of the thing, because this sounds almost like an autobiographical, what is it called, retroactive
Yeah,
rewriting. um
exactly.
and I mean, again, that's not to say it's bad, so to say. I mean, it kind of has something in it, but I don't
Yes.
think it is fair to kind of do it in practice as a therapist.
I think this is a very bad case for perversion. Actually, if you want to understand perversion, you
Yeah,
shouldn't you shouldn't really go to it, because
yeah.
after that she made graphs and stuff that's, I mean,
Hmm.
typical. You would say, you will say that because I'm from French schools. You will say that I hate UK schools, but this is why I hate them. Is because the knowledge is on their side,
Right.
um,
Yeah.
and they they understand too quickly. And that's what's like bothering me, is that,
Hmm.
well, I mean, again, to cite like Lacan and all those
Hmm.
guys, let yourself be taught by the patient
Right.
before making any interpretation about birth or whatever. Now, I don't think her interpretation is totally off, right? I think she is onto something, because you know the Houdini thing. I mean, all that stuff.
Hmm.
that doesn't make a good argument for structure. That makes a good argument for this detail.
Right.
She makes this whole story, and she based that to say that he is perverted. I mean,
Mm-hmm.
come on, it's
Yeah.
not enough, and the diagnosis here doesn't help at all. I think if she removed this um, this idea that
Mm-hmm.
this man is perverted, she would actually build a stronger case for something else, which we don't know what it is, but it's probably in the realm of neurosis, right?
Mm-hmm.
Um, not so much of perversion. I mean, we could argue with that, but we don't have the material for that. So I chose that case because, first of all, it's really hard to find a clinical case that talks about transference
Mm-hmm.
because psychoanalyst takes it for granted almost.
Yeah.
So they don't bother to explain something.
Yes.
And you see the difficulty to put words around this concept.
Yeah. Yeah. Yeah.
She herself refers to some kind of like space where something emerge and they fuse.
Mm-hmm.
Like one, yes, of course, the psychoanalytic couch is has regressive aspect in that sense,
Mm-hmm.
where you're lying down already, you are in a regressive state, right?
Mm-hmm.
You're the baby looking at the ceiling.
Mm-hmm.
Um, so yes, of course, but it's not enough to have a definition for transference. And I'm not even satisfied with the definition of La Planche Pontalis,
Mm-hmm.
right? Which you didn't use, I think.
No, I just only kind of
Uh,
it's
yeah.
like Laplanche and Pontalis tell us that actually it's difficult to define transference because of like so many analysts having so many different views. Because like if you take a very purely Kleinian, not pure, okay, neo-Kleinian orientation, they have a very what is it um magical, so to speak, definition of transference. It's kind of like you try to imagine the
Hmm.
kind of things that might be going on in the patient's mind and then make kind of claims on the basis of that. And then you have Lacan, of course, which is structurally entirely. Um, but I
Yeah.
think like one of the things that this case that we presented is good at doing is kind of tells us partly the problems of transference. It's kind of you can see how
Yes.
like I mean, I guess she was a young analyst around this time, and she has to encounter this kind of unusual sexual thing, and
Hmm.
if we kind of consider this, the whole of transference, you see how this could lead her to certain things like, going to the sex shop or, trying to, learn about these things, which is what kind of transference does, right? If you think about it, in transference, it's like you're encountering something from this patient's
Hmm.
life, which you probably didn't
Hmm.
know, and you would have to kind of curiously try to know about it. But again, the point is try to know it through the patient. Um, so it's, I think
Yeah.
this curiosity aspect is present everywhere, and this is where as you said, learning from the patient starts is by trying to be curious about it. Um, but sometimes the curiosity can actually be more, what do you say, about your knowledge than the patient's knowledge. So yeah, that's the problem there.
Yeah. I mean, here the analyst plays his role of the subject supposed to know,
Mm-hmm, mm-hmm.
But actually, he knows too much. There is
Yes.
he delivers some kind of truth, right?
Mhm.
Which I find so often in UK, or I don't know how to say that,
English
English
stuff. Yeah.
psychoanalysis,
Yes. Yes.
is this need for
Uh-huh.
treatment, this need to say that, well, the truth is this and that,
Mhm.
and actually it's not only in France, it's worse, I think,
Mhm.
but it's not the core of psychoanalysis. The core of psychoanalysis is to stay with that buy-in
Mhm.
mentality, almost.
Mhm.
That's why to me, um, he's great. It's
Right.
because he makes us almost every time we return to this rule that let's not understand too quickly, let's not go too far, because I mean, I always put myself in the shoes of those patients. I mean, if I did go to an analyst, I already suppose that he can help me, right?
Mhm.
And then he tells me truth like this. I mean, I there is something bothering me about this, about not working beyond words, just like
Mhm.
working through this, and not working with language actually, but and that's what she said. We cannot use words. We didn't use words. Um,
Right.
and to be honest, it's also a good case for countertransference,
Yes. Yes.
which is something Lacan. I
Almost
cannot
dismisses.
agree. Yeah, I cannot
Yeah.
agree with his statement on and far worse is Jacques-Alain Miller.
Mhm.
And so I would say Fink, because I think he follows him.
Mhm.
Uh, so Fink, Jacques Miller, and all those guys are trying to see countertransference as something that is unethical. I think that here this is a good case for why is it is important to also consider countertransference as something crucial to
Yeah.
maybe progress in analysis, right?
Yeah. Yeah. I think I don't know. I mean, like, I don't know much about Lacan's critique of countertransference, but I think if you try to kind of go a bit more structural, it's difficult because I was watching this what is it discussion again. My Lacanian guy right now is Darian Leader. I'm kind of reading and watching him. Um,
hmm
and he
I'm gonna
was.
start reading him
Mhm.
because you posted what why we can't we sleep.
Yeah, yeah.
That's really interesting to me.
Yes, yes, it is. So this guy was in a conversation with a few people. So there was an actress, there was a writer, and there was a neuroscientist, and there was Lacanian vegetarian leader. And they were talking about empathy.
Oh,
So, and Darwin Leader's first statement is that empathy is an illusion. It's kind of like he is surprised that we have come up with this idea that somehow I can, so to say, put myself in the place of this person and imagine the feelings that he or she would be going through, right? So he is kind of amazed that how actually can this work. So he kind of says a few more things that, maybe, so for example, if someone tells you that they're really suffering from a lot of things, and the first thing you try to do is, okay, I try to put myself in their position and see what I feel. And then he says, if you kind of try to do that, you're actually worried more about your own suffering than their suffering. Right? Because
yes.
again, the feeling is yours at the end of the day. So again, like I think this is also related to Lacan's critique of countertransference, which is that how can the therapist somehow, be totally kind of, so to say, authorized, like has
Mm-hmm.
authority on what the patient is feeling, right? It's kind of like, I am the therapist, I have a patient, the patient kind of said something in transference, and I have a counter transference, and then through my counter transference I can say, okay, as I had this counter transference, this is the issue with the patient. So you can see this kind of authority or knowledge through counter transference, and I believe Lacan is kind of telling that, okay, you can't actually say that. Like, how are you saying that? This is almost quasi magical. So,
Mm-hmm.
I think, of course, you can have good kind of uses of counter transference,
Mm-hmm.
but often you can, take it into magical directions, like most neo-Kleinians do. So,
Yeah. I agree with that. I think I'm very critical of the countertransference use, but at the same time, I am very critical of the Lacanian dismissal of it,
mhm,
because I think it's somewhere between the two. There is some good
middle
when
ground.
you can understand. Yes,
Yeah.
and actually, Lacanian goes into control, what they call control,
Mm-hmm.
which is a control of the transference specifically. So in a way, they're just changing. Most of them are changing words and not admitting to concepts. But in the practice, they are doing the same thing. They are going to supervision. They are working with affects and working through them. So they control the countertransference. Um, if and well, if you think that and analyze it, I think Lacanian, you know what? It led to Lacanian being silent.
Mm-hmm.
There was a bunch of analysts still today that doesn't say anything when you go into therapy.
Mm-hmm.
They just listen and listen and listen, and they let you. And this is the most. This is the a horrible experience. It's not analysis. It's just silence.
Mm-hmm.
Um, the lack of intervention and the lack of the fear of going into transference is something that divides lots of Lacanian schools today. So I don't know. I don't think I have an opinion about counter transfer. Actually,
Mm-hmm.
I'm just sure I don't want to dismiss it or
Yes.
overuse it. Right,
Yes.
like others. I think this is a very lively question. The counter
Mm-hmm.
transfer thing. It's just that we have to resolve first the affects problem.
Yeah, the affects. Oh
Um,
God.
so yeah,
Yeah.
Puddle said that countertransference feelings, so this affects, those
Mm-hmm.
affects, um, in Lacanian terms, they are understood very differently from the rest of therapies.
Yeah.
There are actually no affects. So you have to understand that all affects lies except anxiety,
Anxiety.
um, which is extremely complex, but those affects means that, well, if you are angry, for example, at a football match, you're
Mm-hmm.
not really angry at that football match when you go into analysis. It's just a representation. This representation lies because it's underneath. There are far more, you know, far different. There are different stuff
Mm-hmm.
linking each other, and you take the football representation to be angry. So when you see someone screaming at your screen, at their screen, um, it's actually something else, right? Um,
Yeah.
yeah.
So yeah,
Whereas other analytic school would take it almost for granted,
as
right?
the starting point, like, what is it?
Yes.
Like, I mean, it's weird to really tell a therapist today that we don't really care about your feelings, or we don't really care about your affects. I was like, what are you doing
Hmm.
then? just kind of,
Yeah,
telling
but
you.
CBT is working with emotions, right?
Yeah, it's like,
And you have those classic
uh
therapists who are saying, "Oh, how do you feel right now?"
yeah, yeah.
Um, you never. I don't. I mean, you can say that in analysis. It doesn't mean that
You're taking it as the
you're
main
taking
thing.
it as granted. Yes,
Yeah,
exactly.
yeah.
Yeah, you cannot work through emotions. That doesn't mean anything in analysis.
Yes, right. I mean, like it's kind of related because like when you see in like CBT, they're asking you about your feelings and they're kind of, noting it down. But at the same time, you can also see why it's kind of fake, so to speak, because um, when you ask about your emotions, what you're kind of telling is basically kind of what you're thinking about yourself and your own situation, and you kind of try to shorten it and say it in one word. So for example, I can be afraid of, I don't know, my exams next week, or my house kind of loan and stuff like that. And all of that, I don't say anything, but I just say fear. So fear as an emotion captures all of this, or is supposed to capture all of this. But like when I say fear to a CBT therapist, he's not going to think about my house or my exam or anything. He's just going to think fear
Hmm.
as an emotion. So you can see how this is problematic, because what does fear on its own means? It doesn't mean anything, right? Um, so
Hmm.
affects are a problematic thing and Lacanian stuff. I need to read. I'm not sure if you've read this. There's the Colette Solar book on that. I have it, but I haven't read.
Yeah, yeah, yeah. It's a thing that translated it,
Yep,
right?
yep.
Yeah, 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 I read it. It's very good. It's a short
Nice.
book, also.
Yeah, yep.
It's a 130 page, something like this. I think, I
Mm-hmm,
believe.
mm-hmm.
So yeah, yeah, and it's actually quite. It's not like in bullshit stuff. It's actually she's explaining herself.
Yeah, Colette Solar is good.
Um,
I mean, I've heard
yeah,
that she's really good.
she's really good. But as an analyst, I think Swan is right from yesterday. I
Mm-hmm.
think good theorist makes bad analyst. I think
Yeah.
this correlates history. Yeah, yes,
Okay.
it was. Yeah.
Yeah.
But as do you have any question? Maybe um, if you want to read the whole thing, because I think you like got in
Missed.
at the
Yeah.
end.
Yeah.
Um, I think maybe Divya, will you
Yeah, you can send the
publish
PDF.
the
You have it?
presentation?
Yeah,
Yeah.
sure.
Okay. Yeah. Yeah. I have it. I can send it. All right. You can read the PDF. Divya made an amazing job doing it. Um, and I think even without the audio, you can read it by its own and it makes sense, I guess. It's
Yeah.
just without our uh, interpretation, I would say,
Yeah, and the
or
recording should be out
or
soon.
commentaries.
Yeah.